and it will address the question, what is meant by the term therapeutic index? At the end of this presentation, you should be able to explain how beneficial and adverse effects of drugs can both be plotted on a dose-response curve, define therapeutic index and explain how it is calculated, and explain why therapeutic index is relevant to prescribers. We've already seen that the dose-response curve provides a description of the relationship between drug doses and the responses they produce. In clinical practice, prescribers are unable to construct a careful dose-response curve for every individual patient. Therefore, most drugs are licensed by the regulatory agencies for use within a dose range that is expected to be at the top of the dose-response curve for most patients. This ensures that most patients will achieve a good clinical response without the need for frequent review and dose increases. However, this means that it is sometimes possible to achieve a satisfactory therapeutic response at doses towards the lower end of the recommended dose range. Increases in drug dose or concentration beyond this range produce little extra response. This becomes important if the drug has significant dose-related adverse effects. Increasing the dose may provide little additional effect and increases the risk of adverse effects. Of course, most of the adverse effects of a drug are related to dose in the same way as the beneficial effects, so it is possible to plot a similar dose-response curve for those adverse effects. For a drug to be successful, its adverse effect dose-response curve needs to be well to the right of that for the beneficial effects. A clear separation of the dose-response curves allows a window of dosage, sometimes called the therapeutic window, for prescribers to be able to treat patients successfully while producing minimal adverse effects. This window stretches from the minimum effective dose to the maximum tolerated dose, the highest dose of a drug that can be administered without the development of dose-limiting adverse effects. The ratio between the doses causing adverse effects and those required to produce beneficial effects is known as the therapeutic index. In this case, the therapeutic index is 100, being the ratio of the ED50 for the dose-response curve for the adverse and beneficial effects. In other words, a 100-fold increase in drug dose or concentration is required to elicit the adverse effects compared to the beneficial therapeutic effects. This is an oversimplification of the real-world clinical practice. In reality, drugs have multiple adverse effects, some of which are more tolerable than others. However, the concept of therapeutic index refers to those effects that would require a dose reduction or discontinuation. The therapeutic index, in simple terms, is an expression of how much room for error there is when a prescriber is selecting a dose for a particular patient. For drugs with high therapeutic index, prescribers could take into account the inevitable intra-individual variation in susceptibility and still expect to avoid any significant adverse effects. For many drugs, the therapeutic index is greater than 50, but there are some notable exceptions in common use that have a low therapeutic index. Although it may seem undesirable to use drugs that have a low therapeutic index, they are still preferable if there are no alternative drugs with similar efficacy. For example, most anti-cancer drugs have a low therapeutic index, making adverse effects highly likely, even when used by the most cautious prescriber. However, the potential benefits of successful treatment make those hazards acceptable. Other examples of low therapeutic index drugs in common usage are digoxin, the antiarrhythmic drug used to treat atrial fibrillation, warfarin, the oral anticoagulant used to prevent and treat thromboses, theophylline, the bronchodilator used to treat reversible airways disease, phenytoin, the antiepileptic drug, and perhaps most notably insulin used to treat patients with diabetes. In each case, doses have to be titrated carefully for individual patients to maximize benefits but avoid adverse effects. This is done by monitoring drug effects closely, either by clinical assessment or by regular blood sampling, a process known as therapeutic drug monitoring. All of the examples of dose-response curves we have looked at are those of the theoretical average patient. However, prescribers never know the dose-response relationships for a particular patient that they are treating. They have to make dose selections based on average data derived from observations in many individuals, upon which are based the licensed dosage range that they are required to use. They hope that by following the guidance provided, based on average data, the benefit-risk ratio will be strongly in the patient's favour. In reality, every individual is unique and will have their own specific dose-response curve for the beneficial and adverse effects, and therefore their own therapeutic index for that drug. It is inevitable that will be some individual patients who have a poor outcome in spite of the prescriber having been careful and followed all appropriate prescribing guidance. This only goes to emphasise the need to treat all prescriptions as a clinical trial for which the outcome is never entirely certain. Prescribers should make every effort to monitor both the beneficial effects of their treatment and for the emergence of unexpected adverse effects. It is important to consider why there might be this variation in response to the same drug doses between different patients. First, there might be differences in tissue responsiveness due to age, sex and disease. For example, a more elderly patient who has impaired renal function is unlikely to be able to produce as much urine in response to a diuretic as a younger, fitter patient. Conversely, a more elderly person might experience more profound drop in blood pressure in response to a vasodilator because they do not have such effective compensatory physiological responses as a younger patient. Second, there may be more fundamental differences in receptor number and molecular structure, and receptor coupling mechanisms resulting from the differences in genetics between patients. For instance, polymorphisms of the genes coding for the beta-adrenoceptor influence the response to beta-2 agonists in asthma. In addition to this inherent variation in pharmacodynamic response to a particular drug concentration, there is significant inter-individual variation in the way equivalent drug doses are handled in the body. In other words, the same drug dose administered to one person can result in a very different drug concentration when given to another. This is the result of differences in pharmacokinetic processes of absorption, distribution, metabolism and excretion, and they also arise from age, sex, disease and genetic differences. Indeed, it is pharmacokinetic variation that explains most of the inter-individual differences in drug response in routine clinical practice. That brings me to a brief review of the key points of this presentation. The dose-response curves for the beneficial and adverse effects of drugs can be compared on the same plot. Therapeutic index is the ratio between the dose of the drug that causes adverse effects and the dose that achieves therapeutic benefits, and can be calculated by comparing the ED50 from the relevant dose-response curves. Drugs with a low therapeutic index require cautious dose titration, and their effects need to be carefully monitored, often with the help of blood tests. There is considerable inter-individual variation in the dose-response curves for drugs, and so, even with a cautious approach, some patients will experience adverse effects. You can find further reading and resources to support your learning at the locations shown. I hope you found this presentation helpful and look forward to you joining me again for more clinical pharmacology at this site shortly.